What if the most reassuring blood pressure reading you get all year only tells you what your blood pressure was doing in that exact moment, and nothing about what it does the rest of the time? Someone sits in a doctor's office. A cuff tightens around their arm. The number comes back fine. They leave feeling relieved, maybe a little proud of themselves. And for a lot of people, that reading really does reflect how things are. But for others, it doesn't. And the gap between those two groups is bigger and more common than most people assume. Here's the uncomfortable part. A single office reading is a snapshot. It captures one arm, one chair, one moment, usually while you're sitting still after driving somewhere and waiting in a room that isn't quite like the rest of your life. What it doesn't capture is the other 23 hours and 55 minutes, including the ones that may matter most. Picture a woman named Diane, not a real patient, just an example of a pattern doctors see often. Diane is 61, walks most mornings, watches her sodium, and has never had a concerning reading at a checkup in years. At home though, she'd occasionally glance at the cuff her daughter gave her as a gift and see a number higher than she expected. She always assumed the home monitor was just less accurate than her doctor's equipment, so she stopped checking. It took a routine conversation, not a crisis, for anyone to look closer. What Diane didn't know is that her pattern has a name: masked hypertension. It means blood pressure looks normal in the office but runs higher during ordinary life, at home, at work, even during sleep. It's genuinely common, affecting a meaningful minority of adults, though the exact number shifts quite a bit depending on who's being studied, whether they're already on medication, their underlying risk profile, and even which measurement method and definition researchers used. What's consistent across that variation is the core finding. A normal office reading alone can't rule masked hypertension out, though it doesn't mean everyone with a normal reading has it either. It also isn't random who tends to have it. Research points to certain patterns showing up more often in people who smoke, drink alcohol regularly, carry extra weight, manage diabetes or chronic kidney disease, live with higher stress or poor sleep, or have obstructive sleep apnea. None of that means any one of these automatically causes masked hypertension. It means these are the situations where an out-of-office check tends to be more informative, not less. There's also a mirror image pattern worth knowing because it's easy to confuse the two. White coat hypertension is the opposite. Blood pressure that runs high in the clinical setting, often from the stress of the visit itself, but normal the rest of the time. It's genuinely common, and research suggests it isn't always as harmless as it once seemed. Some studies have linked it to somewhat higher long-term cardiovascular risk than being consistently normal everywhere, though not as high as sustained hypertension. If masked hypertension is a false reassurance, white coat hypertension is a false alarm, one that's still worth understanding rather than dismissing outright. Both patterns exist. Both are well documented. And the only reliable way to tell them apart from a single office visit is to look outside the office. So why would blood pressure change so much depending on where and when it's measured? Because blood pressure was never meant to be a fixed number. It shifts with activity, stress, sleep, meals, caffeine, posture, even how full your bladder is at the moment of measurement. Think of a single office reading as one photograph. It might be perfectly accurate. It's still only one frame from an entire day's film. One part of that film matters more than people realize: nighttime. In most healthy people, blood pressure naturally falls somewhat during sleep, a pattern researchers call dipping. But in some people, it stays elevated through the night instead, sometimes called non-dipping. This isn't a diagnosis by itself, and the pattern varies person to person, but persistently elevated nighttime blood pressure has been linked in research to a higher risk of cardiovascular events. In some studies, more consistently than daytime readings alone, which is part of why out-of-office measurement can reveal something an office visit structurally cannot. Across large studies following people over years, sustained high blood pressure, whether caught in the office or only visible outside it, has been consistently associated with higher risk of heart disease, stroke, kidney damage, and vascular changes linked to cognitive decline. The mechanism broadly involves the constant low-grade extra force circulating blood places on artery walls in the brain, the kidneys, and the heart alike, over years rather than days. This isn't cause and effect from one reading. It's a pattern that builds quietly the way water finds its way through concrete over years, not overnight. That's precisely why catching the pattern matters more than catching any single number, and why researchers increasingly treat out-of-office readings, particularly nighttime ones, as carrying real independent weight in understanding someone's actual risk. So how is blood pressure actually supposed to be measured? It sounds almost too simple to matter, but technique changes numbers more than most people expect. Sitting quietly for a few minutes beforehand, back supported, feet flat on the floor, arm resting at heart level, using a properly sized cuff, and staying silent during the reading, all of it affects the result. Talking during a reading, for instance, can meaningfully raise the number. So can a full bladder, recent caffeine, or measuring immediately after climbing stairs. None of that means anyone is doing it wrong in a blaming sense. It means a single rushed reading taken under less than ideal conditions was never designed to tell the whole story on its own. This is where home monitoring earns its place. A validated upper arm cuff-style monitor, checked periodically for accuracy, can capture readings across ordinary days rather than one hurried appointment. It's worth being clear here. Wrist devices and cuffless smartwatch-style sensors are convenient and the technology is developing quickly, but accuracy and clinical validation still vary a lot between devices, so unless a specific one has been independently validated, it generally shouldn't be treated as equivalent to a validated upper arm cuff for the kind of numbers that inform medical decisions. Multiple recent readings taken consistently and recorded rather than remembered give a far clearer picture than any single number, high or low. For some people, home readings alone still leave a genuine question mark, especially around nighttime patterns. That's where 24-hour ambulatory monitoring comes in. A small portable device that measures blood pressure automatically every 20 to 30 minutes through a normal day and through sleep. It's not something everyone needs, but when office and home numbers disagree, or when nighttime patterns are the specific question, it can reveal what neither a clinic visit nor daytime home checks can. The 2025 AHA-ACC guideline, the major US update to blood pressure guidance and still the most current as of this video, reinforces this shift. It's the first major revision since 2017, and it reaffirms a treatment target below 130/80 as the overarching goal for most adults, while making clear that the right target and treatment approach still depend on individual clinical context, other health conditions, and in some cases, exceptions your own doctor would weigh, not a single rule that applies identically to everyone. It also introduces a newer risk calculator that factors in kidney function and other health measures to individualize decisions rather than applying one blanket rule. It places real emphasis on accurate measurement, on home monitoring as a genuine clinical tool rather than a nice-to-have, and on team-based individualized cardiovascular risk assessment rather than treating every patient against one identical number. European guidance, most recently the 2024 ESC guideline, has moved in a similar direction, with a stronger emphasis on out-of-office measurement shaping how blood pressure gets classified in the first place. Where American and European guidance differ on specific thresholds and categories, that's a real ongoing conversation in medicine, not a sign that one side is simply wrong, and it's part of why this is genuinely something to discuss with your own doctor rather than settle from a video. So what does this actually mean for you? It doesn't mean panicking over one reading, high or low. It means understanding that a single number taken once wasn't designed to capture a pattern that unfolds across days and nights. If your office readings have always looked reassuring and nothing else stands out, that's genuinely good information, worth continuing your routine monitoring and healthy habits rather than second guessing. If your home readings keep running noticeably higher than your office ones, bring the log to your clinician rather than sitting with it alone. If office and home numbers genuinely disagree, ask whether ambulatory monitoring makes sense. If risk factors like diabetes, kidney disease, sleep apnea, cardiovascular disease, or a strong family history apply to you, it's worth raising out-of-office monitoring proactively, even without a specific concerning reading. And if a single home reading comes back unexpectedly high, the right response isn't to diagnose yourself on the spot. Rest, repeat the measurement correctly, and consider the context, not just the number. One clear exception: a reading around 180 over 120 or higher, especially with symptoms like chest pain, shortness of breath, vision changes, or confusion, is a different situation entirely and warrants emergency care, not a wait-and-see approach. Beyond that, keeping a simple, consistent record is far more useful to a doctor than a handful of scattered readings. And none of this replaces medical care or means changing how or when you take any medication without your clinician's guidance. Diane, for what it's worth, kept the cuff her daughter gave her. She just stopped assuming it was wrong. So here's a question worth sitting with. The next time your blood pressure looks perfectly normal in a doctor's office, will you wonder what it's doing everywhere else, or just trust that one moment to speak for all of them?